at, I suppose, a higher level of occupancy, so almost 50% in terms of our inpatient occupancy in May overall. And bearing in mind that our aim is to work at an 80% occupancy, they're at about 2/3 full in terms of inpatients, but critically they're at about 80% in terms of day cases. So we know that actually they're higher, sorry, I forgot. So they've gone up to over 100%, so they're 158% on Friday. What that means is that in the private hospitals, they're now turning over day beds with more than one person in a day. So very significant activity going through in terms of day cases. So I think that the message is that we are getting busier, we're seeing a lot more people, and we have to look at how we can ensure, as Paul said, returning to health service provision in a COVID environment. So COVID isn't going to disappear, and our challenge is to ensure that we can deliver services for everybody. Paul has mentioned testing, so I won't go into that. In terms of our, I suppose, our disability services, as you said, that's going to continue over the coming week and be closed out. Our community assessment hubs continue to be relatively quiet. So we have 29 open, but the referrals are quite low. We're now looking to see how the community assessment hubs might support the return to other services. As you'll be aware, we have multidisciplinary teams in those sites with GPs, and we're now looking to see what the best use of some of those quieter hubs might be, and Colm and I are working with teams around that. The self-isolation facility continues to take referrals, so we've had 578 to date. And, you know, again, they are for people who have been returning, so we are taking some people who are returning to Ireland to work in our health service for isolation, as well as people who've been identified by public health. When we talk then about the support to long-term residential care facilities, we are now supporting 804 locations. Now, it's important to stress that that does not mean that we have 804 facilities with outbreaks. These are just the locations that we provide support to. You'll be aware that previously we've talked about a red, amber and green categorisation, but we've introduced a new one, which is a white one. And really what that means is that we are now trying to capture the residential facilities that are stable completely and are only on our radar for regular, normal PPE delivery schedules and other pre-COVID interactions. So we would see that that is now a normal way of doing business where we provide PPE. It's no longer exceptional. And of the 804 facilities, 448 of those are now in that category where they are on our radar purely for normal PPE deliveries. Out of the remaining facilities, we have only got 7 that we now would have in our highest category of concern, and 72 then who would be operating still with a level of significant support, but 277 in what was the green category. So we can see a very considerable shift towards a stabilisation in long-term residential care across all areas. The breakdown within that is 433 are relating to older persons, 234 for people with disabilities, 81 mental health settings and 56 others. So we will continue to provide support as required, and again there's a level of normalisation coming into that. We continue to have 435 staff deployed to residential care, and 66 of those 97 facilities are relating to older persons. So just in terms of the PPE deliveries, we have over the past week delivered over 10 million items of PPE. 38% of those have gone to residential care, 25.4% to home care, and acute services are just under 16%. We had on just Thursday, Friday, delivering to over 600 locations, so 635 locations now in receipt of PPE from the HSE, and that is continuing to grow. In terms of our staff accommodation, we have now got 1,487 beds occupied by staff, and within that we can see that there's 29% from private nursing homes. So again, that is coming down. Actually, it's gone up since last week, but overall coming down considerably. The number of requests have also come down slightly and are now 216 in the past week. So again, not as many people, but we still have quite a lot of beds being occupied to support staff who can't stay at home as a result of COVID. Just a final thing for me in terms of our return to business, and again important to say that it's not going to be just COVID and non-COVID. It is for us the challenge of delivering all health services in a COVID environment across acute, community, cancer screening, etc. But just indicative of what we're trying to do that's different would be the use of telehealth. And in terms of outpatient activity in particular, we have been looking at the use of Attend Anywhere across services. Our outpatient services nationally would see about 280,000 people in a month in a pre-COVID time, so quite a high level of activity, and that reduced very significantly. However, with the introduction of Attend Anywhere and the use of telehealth, we've seen, I suppose, a reintroduction of a significant amount of outpatient activity. And we've been looking at how we can mobilise and expand the use of telehealth across our outpatient services to support virtual consultations. In March, we saw that we had just under 37,000 consultations by virtual health or by Attend Anywhere and telehealth. In April, that has gone up considerably, so our data now for April tells us that there's just under 81,000 consultations in April, which would be virtual consultations. And I think, what we are finding across all of our sites, so we now have 36 sites reporting on virtual consultations for outpatients. We would see this as something that we will build on considerably over the coming months. Interestingly, when we look at the attendances at our virtual outpatient consultations, we can see that there's a do not attend rate of only 3%. So people are very keen to engage virtually, and that is a considerable reduction on what would normally be a 14% rate of non-attendance at outpatients. So we are going to continue working with services on that and support both acute and community services to be able to do their business differently over the coming weeks and months. So I'm going to end there and hand over to Philip. Thank you.
Good morning, everyone, and thank you for coming. I'd like to go over some points associated with the impact of COVID-19 on mental health. I'd like to share some information on mental health services, and I'd also like to give an overview of the psychosocial response that's now underway in the HSE. I'd first like to begin by maybe acknowledging that the challenges of this pandemic and its associated restrictions have impacted in a variety of ways on the mental health of everyone in the country. People have become sick, others are worried about becoming unwell. Some of us have lost loved ones to coronavirus, and others might feel the strain of how life has become much more restricted in various ways. Ireland is certainly not alone in this regard, and as Paul referenced earlier, as highlighted in a recent WHO briefing on the impact of COVID-19 on mental health across the world, Ireland is obviously in a very similar position. The impact of COVID-19 on mental health will be different for everyone, and it is true to say that we are all being challenged in new and varied ways. However, it is also important to remember that the majority of our population can and will adjust to the new circumstances and can recover from the impact of COVID-19. A bad mental health outcome is not inevitable. In general, indicators of COVID-specific public sentiment and some clinical research are telling us that people are currently adapting reasonably well, becoming less worried and settling after the initial arrival of the virus in Ireland. Indeed, we have probably all seen some inspirational examples recently of how communities have come together, reached out to those who might be isolated and nurtured in a new connectedness with others. This can bring us a wonderful sense of hope and belonging, which in itself is a very important protective factor for our mental health, helping us to hold firm individually and as a country. So just turning to our mental health services and supports. So like health services in general, mental health services have become disrupted during COVID-19, but have remained operational and accessible. Looking at our own data over recent weeks, our mental health services are reporting to be busy, but not unusually so, and they have the capacity to respond to current levels of service demand. In order to adapt and improve accessibility to our services, similar to what Anne has referenced, the HSE and many of its funded NGO partners have successfully fast-tracked new telehealth options, for example, innovative online, text and phone therapeutic supports that many people have turned to for the first time. Many of these have been in development for some time as part of a range of digital mental health initiatives underway in the HSE, while others have been developed specifically in response to COVID-19. Going back to our general mental health services, I would like to emphasise 4 key points. 1. Anyone who is already engaged with the mental health service should stay connected with that service. Community mental health teams are still available. In many cases, face-to-face clinical work continues for relevant people with appropriate physical distancing and PPE in place. 2, anyone who is not engaged with the HSE mental health service but is concerned about their mental health should contact their GP. The main access point to HSE mental health services is your GP, and they are available to you as usual. 3, other mental health services, including those services provided by our funded mental health NGO partners, are detailed on yourmentalhealth.ie, or you can call the Your Mental Health information line on 1800 111 888. And lastly, a reminder that our emergency departments are fully operational. So during a mental health crisis, or if you are at immediate risk of harm, then we would strongly encourage connecting with emergency services and your emergency department. So before closing, I'd just like to turn to the HSE Psychosocial Response Project. So this is very much COVID-specific work that we have initiated. We're now coordinating a psychosocial response project to address the overall COVID-19 emergency and its impact on our mental health and well-being. The focus of this work is to develop a framework for psychosocial structures and responses for both the public and all health sector workers in line with international best practice and evidence. Already, the HSE and other funded services have been delivering a variety of psychosocial response interventions. Initially, there has been a particular focus in providing immediate psychological first aid and bereavement supports to affected individuals. These approaches aim to address the overall well-being, resilience, and mental health of affected people. For some, the stress will be experienced over a longer period of time after the immediate challenge of this crisis has passed. Priority groups requiring our particular attention include people who have been bereaved during the pandemic, healthcare workers who have worked tirelessly during these times, as well as some particular more vulnerable groups in the general population. To date, in a short time, our psychosocial response work has helped to align and mobilise a support helpline for health service staff, dedicated support information on the HSE Corona website, COVID-19 website, self-directed innovative online support programmes, as well as enhanced access to therapy and mental health services. So just to close, I think we're reminded during these times that there could be a new group of people emerging who for the first time may have noticed something challenging about their own mental health. For example, those cocooning, those out of work for the first time, or those struggling with anxiety while their everyday life has changed. We would really encourage you to take some time to read up on trusted information and advice for yourself and others. Try to take deliberate notice of what's going on for you right now, and never hesitate to reach out and contact a support service. They are available for everyone, regardless of your past experience or current situation. Thank you.
Okay, so thank you, Paul, and a particular thank you to Philip for coming in today to give that important information and messages out to everybody who's tuned into this today. Okay, so we'll get into the Q&A, and as usual, I know you all. If you can introduce yourself and the organisation you're asking the question on behalf of, so that the people looking in at home knows who's asking the question. And I can see Ben's hand up there, so we'll start with you, Ben.
Ben Finnegan, News Talk. Just looking for an update on the app. Is it still ready to be rolled out at the end of this month?
Yeah, I can take that. Yeah. Ben, we've made the progress that we expected to make in terms of the technical development of it. We're about 95% there in terms of the technical solutions required for launch. We're still closing out one piece between Apple and Google, which is the API, an interface to support it. The intention is to bring a memo to government, obviously in terms of which would be an initial soft launch, and then following that a full launch across. So technical issues have been worked through. The final two pieces, it was, as far as I'm certain, submitted to the AG's office on Friday. This is in terms of our approach to it, and a DPIA will be submitted to the Data Protection Commissioner next week. So technically we're still on target, but we've go through some processes over the next couple of weeks.
So the timeline of it when it being launched on the App Store and open to the public, has that changed now from the end of May?
Yeah, it'll most likely be in June before we've gone through our technical trial, which we've always said we would do first, before it's a widely public available. And that's what we will be doing first.
And how long will the trial take?
We don't see the trial lasting too long, probably a couple of weeks. It's just really to assess the look and feel of it and how it drives the right behaviours from people, to assess it over a period of weeks.
Okay, that's you, Ben? Okay, Liz?
Hi, Liz Farsacci, Irish Mirror. I have a few questions. Maybe I'll just start with two, and then if there's time, we'll ask the other ones. First of all, Anne, you mentioned that since restrictions lifted, there's been an increase in hospital attendance, if I'm not mistaken. Maybe you could remind us again what that was, and is it COVID and non-COVID patients, or is it just, have we seen an increase in COVID patients? And then secondly, perhaps for yourself, Dr. Henry, or someone else, now that we've lowered the R value of the community, and thankfully, due to everyone's work, the infection has lowered now. How does that compare now to other diseases such as the flu? Are we basically at a, I suppose, safe enough, or are we at the same level of safety or non-safety and risk and non-risk as with other diseases that are always with us in the community?
Okay, start with you, Anne.
So, just in terms of attendances, yes, we are seeing an increase in attendances now. We're still lower than we were, as I said, about 22, just under 22% lower than the same period last year overall. But the growth in attendances in the main relates to people who are over 75 years. And that is in the main non-COVID. So our people who are turning up at emergency departments are being asked if they suspect they've COVID, or they're phoning their GP. They're being sent perhaps to a clinical assessment hub in the first case. But that's predominantly non-COVID, normal activity returning at a higher rate.
So people just feel more comfortable to
People feel more, yeah. What we find in general is that many people are referred by their GPs as well. So the rate of admission, so people feel more comfortable, but they're also sick in terms of people who maybe haven't been attending for some time, and they are now being referred or being advised to go to emergency departments. I don't know what you want to add to that.
No, just it's predominantly, as Anne says, a return to of patients. We've seen some explicable drops in people presenting, probably out of fear more than anything else, and other drops in activities such as stroke, which are very hard to explain due to people just being afraid to attend. So what we're seeing now is a resumption of normal patterns of disease presentation that we would see in a non-COVID environment. And it's certainly welcome in the sense that none of us want to think of people staying at home, not seeking help or not seeking intervention, when that intervention might make them better. The second question is on the R value. Do you want me to press that? Yeah. So just...
How does it compare now to other diseases within the community? Does it have implications for...
It's a good question. The R value, as we've all become very well versed in, is a value that tells you how many cases one index case will infect. So measles, for example, has a very high R value of 15, but measles has a vaccine. And thankfully, the great majority of the eligible population take up the measles vaccine, which means that the R value, the true R value after vaccination is much lower. Secondly, influenza you referenced, the R value is 1.5 to 2, but again, influenza has a vaccine. So therefore, the effect of the multiplicative effect of people infecting each other and other cases then infecting each other is stunted, like measles, by the presence of a vaccine. COVID has an R value of 2.5 to 3, maybe higher in certain circumstances, but there's no vaccine and there's no treatment. So the only treatment is to keep apart. And hence, your question about how it compares to other diseases, we can't really compare, but for other comparable diseases, there is a vaccine and there's other interventions that mean that there won't be unconstrained transmission, which there would be in COVID if we hadn't brought in those measures that were introduced on March 27th. the natural, measles is probably the most extreme example. If measles were left unaddressed and nobody became vaccinated, it would be a highly contagious illness that would run rampant across our population and cause serious morbidity and even mortality. But we have a vaccine that's very effective, and I would encourage people, as with any of our illnesses that can be vaccinated, to take those vaccines up. Influenza, similarly, there's a vaccine that's effective, but not for COVID, and it does not look likely for the foreseeable future that we will have a vaccination. Therefore, the only treatment would be for us to keep are those measures that were introduced, and how we refine those measures as we go forward into, I suppose, a more settled era of reduced community transmission.
Okay, that you, Liz? Okay, Orla?
Hi, Orla O'Donnell from RTE News. Just two questions. First of all, the Labour Party has issued a statement, I think this morning, suggesting that if the social distancing was brought down from 2 metres to 1 metre, that would have huge implications for helping to reopen the health service. So have you any comment on that, on whether that might be an issue going forward, about if you had a 1 metre social distance, you could bring in more services, you could get back to some kind of normality quicker? And the second question is just, have you any reaction to the Sunday Business Post story suggesting that nursing homes were told not to tell family members about the cases in nursing homes?
So you take the 1 metre and then column to...
Yeah, just on the 2 metres and 1 metre, from our perspective, obviously the NEFIT guidance and government guidance at the minute is the 2 metre, and that's what we are planning in terms of our framework for new services to work through. Obviously that does have significant implications for us in terms of emergency departments, outpatients, waiting rooms, etc. So 2 metres will reduce certainly the volume that we could have attending at a particular time. But we have to work off what the current guidance is. Current guidance is 2 metres. There's no doubt 1 metre would certainly give us significant extra capacity in terms of managing our outpatients departments, or managing our EDs, or generally managing our services. But we'll be guided by what the current guidance is from government through NEFIT.
Just been columning on the same question.
Yeah, it's important for us all to remember that what's happened since March the 27th, to go back to your colleague's question with the R value, when we had the spectre of uncontrolled community transmission, and it was only through the measures that were brought in March the 27th, which were quite stringent, but included social distancing of 2 metres, that we were able to not just bend that curve, but really reduce it down to where it is now of 0.5. So there is variability as to how this is expressed internationally. We see many countries, including the United States or the UK, include a distance of 2 metres, bearing in mind that it's a droplet spread illness. But as Paul said, this has implications for our own service and clearly for services and businesses outside the HSE. But it's based on the projected length a droplet can spread. Initially, we thought this was primarily through coughing and sneezing. As we get a greater understanding of this virus, we're more aware of how it can spread in less obvious situations, and indeed how it can spread from people who are asymptomatic or pre-symptomatic. So, as Paul said, in the HSE, we're governed by the decisions of NEFIT and how they advise based on the best international advice. And that will be informed also by other countries and how they're emerging out of the initial phase of this pandemic, and how they're refining that distance or otherwise. But for the moment, it is 2 metres based on the best available evidence we have.
Okay, on the Sunday Business Post.
Yeah, I mean, I just read it this morning, just in terms of, but I think I can't comment for NEFIT, but I think NEFIT had made a comment that it wasn't a direction from NEFIT. But specifically, it's not.
It's not something that would have applied in the HSE-run nursing homes, or would it? There was no direction not to tell families about cases in the homes.
We've been capturing the data as much as from the very start of this and into our CRM system, to whatever extent we can. That's what we've been doing.
Just bring Anne in on that.
Yeah, no, I mean, I think the communication with families has been something that has been discussed, and I know people have expressed concerns around communication. I suppose just to put a context around that, what we have found in some of our units is that our staffing has been reduced significantly. We have a much, I suppose, smaller number of staff available to care for patients, and we haven't had as much opportunity to talk to people and to engage as we might in a non-COVID world, purely because of the work demands in particular units. But there's been absolutely no suggestion that we wouldn't communicate. It has just been around the capacity of staff at a given point in time to be able to talk to people on phones, etc. So we are very clear that communication is important, and particularly in long stay units where people aren't seeing family members as much, communication is critical. And we are very, I suppose, keen that all services will communicate as effectively as possible. But we do have to remember that many units have been working in a short-staffed way throughout this period. Our absenteeism that is COVID-related across our services is still at about 1,500 staff. So we are managing in a tighter way than we normally would.
That's you, Orla. Priscilla? Priscilla, yeah.
Priscilla Lynch, Medical Independent. 3 different topics. So first, just onto testing. We've 310,000 tests completed. How many people does that equate to? Because some people would have had multiple tests. Just some clarification on the nursing home figures. We were told 58,000 people needed to be tested in total, staff and patients. But I've seen figures that was just actually 42,000 tests that were carried out there. And also our capacity last week was just about a third. 35,000 tests were carried out, so that was just about a third of the capacity there. Are there any plans to mass test other cohorts or to try and ramp up the usage of the capacity there? And I've 2 other questions I'll ask after.
All for you, I think.
Yeah, just on the last one, the numbers are certainly down on our capacity that we've built up, and that's largely driven by the transmission of the disease in the community, and it'll be always driven by the case definition and any targeted initiatives that we have in terms of public health focus, and that's an ongoing discussion with NEFIT in terms of the public health strategy to it. But certainly from the case definitions we're seeing that are there at the minute are quite wide. We're seeing reduced numbers of people coming through for referral, so it's just a function of demand at this moment in time. The second question was around the numbers of people tested in nursing homes, I think it was overall. There's a total population across the 3 of them. I think between mental health, disability and nursing homes, I think specifically nursing homes is about 28,000 staff and 30,000 residents overall in it. And then across the range, I'm not sure the total population, I think it's 90,000 altogether.
Yeah, it's about, I think in total they come together between disability and mental health. And
that's staff and residents. So, but we have completed a test of all the nursing homes, of all the staff and of all the residents in the second one. The first question, sorry again, if you can just remind me.
Mass testing, do you want to?
The amount of people who have been tested as opposed to...
Oh yeah, it's a very marginal number. I don't, in fairness, this question has been asked before. I will get it for you, but it's a very marginal number of people who would be tested repeatedly. So it's pretty much a high volume of single tests for individuals. Of the 300,000, the vast majority would be. Yeah, we can get the numbers of people. Yeah, we'll try to get it.
Priscilla, on the mass testing issue, we have Lorraine Doherty, your National Clinical Director of Health Protection, has completed a testing strategy which is going through the HSE and is now at NEFIT. And while I won't preempt the outcome of that NEFIT discussion in that document next week, suffice to say that the exercise in nursing homes and residential care settings shows the limits of a mass testing exercise, because the positivity rate among staff and patients, while it's variable across the country, is overall quite low. And it's important for people to remember a testing strategy. It's a point-in-time exercise, and it doesn't afford protection. It's not a control measure as such. That the real control measures are early case identification, isolation, those public health measures, the outbreak management, and the outbreak management in some settings may determine that there would be mass testing in a particular setting, given if there's a particular volume of cases, if the setting is particularly congested or tight or so on. But the most important learning from the exercise was it's as a single point in time exercise, it's very limited and isn't an effective control measure. It doesn't replace the other infection prevention control measures, the other aspects of outbreak management, which are much more critical in preventing dissemination of the virus.
Okay, Simon.
Thanks very much. Simon Carswell, The Irish Times. Just want to ask you on 3 areas, if I could. Given that the private nursing home sector represents about 80% of the overall sector, would you have a view as to whether they should be represented on the expert panel that has been set up by the Minister for Health? Start with that one.
That's ultimately a call for government, for the Minister in terms of the nominees to that panel. I'm sure he's given wide consideration to it, and I expect there will be deep engagement across the sector on it, but ultimately the nominees are a decision for the Minister.
Just in relation to nursing homes as well, Anne, you mentioned the figure about the number of people that are not being discharged as quickly. I'm just wondering, this is probably for Colm actually, with regard to the protocol for discharging people, elderly people from hospitals back into nursing homes. Should there be testing done as a matter of course, even for nursing home residents being discharged from non-COVID wards back into nursing homes, to give those nursing homes the reassurance that they're not going to be getting a COVID case back into their homes, given the vulnerability of those settings?
That's a good question. Currently, as you know, anybody who's a proven or suspect case has to have 2 negative tests before they return to such a setting. What I would say is, while there's no blanket diktat that says that everybody should be tested, that the bar is set very, very low within hospitals. I know that. So they would have a very low threshold for ordering a test on any elderly resident, given the fact that we know now that there's asymptomatic carriage and that there's atypical presentation in older people. So while I can't say that there's a blanket diktat that we test all people returning to nursing home settings, there is a very low threshold for carrying out that test in hospital settings.
Just explain that low threshold. People might take that up incorrectly.
Sorry, meaning that it doesn't take much to order the test. Hospitals, because we've seen from the case definition that it's become more broader and broader still. We're now talking about bringing on the loss of smell in the coming week, like the UK. But in older people particularly, we know that only 1/3 of them have typical symptoms of respiratory tract symptoms or fever. So any other symptom, or indeed people just going off or not being themselves, there's a low threshold for testing within hospital settings in the community.
Just in relation to the agreement with the private hospitals, and you touched on some of the occupancy rates, it's almost 50%, which is still quite low. There's a snapshot survey done by private consultants on Friday, and that was about 35%. Based on those vacancy rates in private hospitals, the suppression of the disease and the potential to harm patients and the loss of taxpayers' money with regard to those private hospital contracts, is the contract to take over those private hospitals, is it still worth it? Are the reasons that were there in March still there now, Paul?
Yeah, well, if you take, just to answer the end part of the question first, the reasons that it was put in place from the start was to ensure we had capacity to meet surges as we've progressed through the management of the disease. Obviously, we've now, in terms of the suppression of the disease, that's been managed very well by the public and everything we've been asking the public to do, which is reduce the transmission. However, if you take all the guidance from WHO, ECDC, it is about, as you begin to introduce or remove some restrictions, potential impact on the community, can see either a second surge or can see peaks again in terms of progression of the disease. We have to, in the HSE, be very mindful of that. And you know, on a good day, normally pre this, we would operate at 95% capacity level in the hospital. WHO guidance is you should be aiming to be at 80% occupancy levels, and that's a very significant risk for us. So looking forward, we need to keep capacity levels. We need to protect the public in case of a potential surge or potential further peaks as restrictions are lifted. So in terms of the driver of it there at the start, it actually still is with us, the driver that was procured for in the first place. Looking forward into the future, you know, would it all be done differently? That's a question for the future. But right now, the original driver, we still need to keep capacity.
Just clarify the occupancy rate.
The occupancy rate can vary hugely. I'm not familiar with the survey that you just quoted, but you can see some occupancy levels very high in some private hospitals and lower in other. And certainly in terms of day cases, you can see day cases are running at about, bed levels on day cases are running about 158%, which means a lot of day cases turning throughout the day. So occupancy levels would be the average. I think Anne just quoted below 50%, but it can vary hugely.
Okay, Cliona. I'll come back to you, Simon, for your last question. Yeah.
Oh, sorry.
Yeah, no, Cliona, you're up now.
Sorry, just a quick one. The meat plants and the outbreaks there, it was mentioned last week that quite a few of the workers in these meat plants are foreign workers and they may live together, which could be a problem in terms of the transmission of the virus. There was talk that accommodation had been provided to some of these workers by the HSE, I think. I'm just checking to see, do you have figures as to the number of accommodation units that's been provided, the number of people that are being accommodated who work in meat plants?
I don't. No, sorry, I don't. I know we have our, so if Public Health consider that people need to access self-isolation, we do have City West, but I don't have a breakdown of any numbers. Sorry.
But just on that point, Simon, it is a critical part of the outbreak management, because people presume, much like the healthcare workers, that the transmission occurs solely in a work setting. It doesn't. In many cases, in not most cases, transmission can occur out in the community, and it's as much a function of where people live and how they live, rather than where they work or how they work. So a critical part of the outbreak management would be those local public health teams advising, working in a multi-agency way, with the owners of the meat factories and with the workers to advise strongly on the whole menu of measures that were necessary to break transmission of the virus, which would include, of course, isolating people, and would include looking at living arrangements, particularly where there's areas of big volume in outbreaks.
Okay, Cleona.
Thank you. Cleona Russell, Virgin Media News. Just two quick questions for Anne. First, on the community assessment hubs, you were saying, that they're quite quiet and there might be some other purposes for them. Has there been any discussion about what those purposes might be? Is there any suggestion around that? And also with the virtual health consultations and saying the do not attend rate is very low, do you see this as something then after COVID-19, when that day finally comes, that it's something then that could be used in a larger scale because of that?
Okay, so in terms of the first question, so the community assessment hubs, in a way, could do many things. From our perspective, when we look currently at how there's a significant increase in older people presenting, so we already have an integrated care programme for older people with integrated hubs operating around the country pre-COVID. And they have continued. And I think for us now, when we're looking at the data of who's attending and who's appearing at EDs, etc., there is definitely scope there for us to look at multidisciplinary assessment of people. Our priority will be to ensure that we, a bit like what we prioritise anytime we're busy, whether it's in winter or even in line with what Launch Care would say, is to see as many people as possible away from acute hospitals. So where it is appropriate and where we have access to the right professionals, that we would see them in other environments and in community settings. And our clinical assessment hubs absolutely provide for that. So we're looking at the minute to see where we are busiest or where we have capacity, just to shift that focus. One of the key things that we have to, I suppose, make sure we have access to would be diagnostics. So if you have somebody who's presenting with something, we need to be able to have the right diagnostics available. So that's part of our work that Colm and I are working with the different teams across the community and acute settings on now. And just in terms of your second question there, absolutely. I mean, telehealth has got to be a way forward. It would have been anyway, so we were starting to do some work on this before COVID came, and COVID just accelerated it. But I think for anybody, again, looking at how we can see people. So we have previously done some work where primary care services could access specialist consults using telehealth. And for us now, the way that this is rolled out, and I suppose the uptake of it is very telling. People are very happy to be seen remotely and to not have to attend in busy hospitals, etc. So that is something that we will absolutely continue and build on.
Okay, thank you, Cleona. Okay, we've gone around once. Ben? Liz?
Two more questions and then I'll stop.
That's okay.
Sorry, Liz from the Irish Mirror. Philip, you mentioned the two questions. You mentioned a group of people who might be facing issues for mental health issues for the first time, and including people who have been unemployed. How do you provide support to that cohort of people when really it's the circumstances that have changed for them, and circumstances won't necessarily improve? They won't necessarily get the job back. Kids won't go back to school for a while. They won't be able to travel holidays and stuff like that. So how do we provide support to that new group of people, particularly when a change in circumstances is what might actually be of most help? And then secondly, more of a numbers thing, I'm trying to figure out, so what percentage of those tested are positive? Is it 24,000 out of 310,000? Maybe, I know you've probably said it before, but maybe just say it again. Yeah.
Okay.
Thank you.
Philip?
Yeah, it's a really good question, and obviously you can't whitewash over the realities of life pre-COVID, during COVID or post-COVID. But I think what we try to do as a health service is really offer the layered approach and really trying to work with individuals' own personal resources, be it their own personality resources, their own family resources, or indeed their community resources. So some people will simply require access to accurate information, maybe affirming that the feelings that they have, the feelings of frustration or sadness, are actually reasonable feelings to have, and maybe just need information on trying to very much do some self-help. Others may require a little bit more support. Some may require one-to-one support, be it remotely or face-to-face. And I suppose I would add that our mental health services are really celebrating the fact that we've got multiple interfaces now to potentially work with the population in a more choice-driven way. So for some people, actual face-to-face attendances at clinics present a very significant challenge, and therefore being able to offer a number of different options around support, I think, is a hugely valuable thing, and I would see it as one of the positive dividends coming out of COVID-19, if we can possibly seek some positive dividends. So I suppose what the point I'm really saying is it's a layered approach. We try and work with individuals' own resources. We try and provide, obviously, timely information, accurate information, offer one-to-one supports, and then for those small percentage of people who actually go on to subsequently present with new onset, significant mental health problems, obviously access to our mental health services are then supported.
Okay, thanks, Philip.
On the testing, the positivity rate or negativity rate, it's a function of a point in time. So you will have seen, and we will have seen, at some point in time we would have been about 25% positivity rate when we were testing a lot of symptomatic people in the population. As the transmission of the disease has reduced and almost eliminated in the community, obviously we're testing a lot more asymptomatic people, and even our targeted campaigns over the last few weeks in nursing homes testing. So it's a point in time. So if you take last week as an example, we tested 30-odd thousand, we completed 30-odd thousand tests. 98% of those tests will have proven negative.
Okay, that's you, Liz. Orla, in Keshtas, Gaelga, Quig, Dr. Henry.
Just for a column on Keshta Churme or Paul Reader in Eastliha on Scara Socialta tá éile bhean beidir go bhéitfá huairt síos go méidir a bháin seachas chábhéidir agus céir é bharúil fa sin.
Well, tá sé tábhacht chorgah de an duine go chruid cosc ní choscomlan tá géiste cosc ar scapo an vírus tuisce gur bhuiid ilig mar sochaí agus mar réí mar go phobal ag clí leis na rialta agus mar legur síos iad ar an seatalás fiad a mína bharta. So sé táhaach go bhuiid ag clí leis na multi inis agus a maihan seo. Ach sin ráte is agam ghfuil na riala tuiscúil na rialacha céarna a bhain sa bhrátan agus sa bhericha tá réarc eile ag tíortha eile ach fu leithre inis an trátaise tá agine ná clí leis na multi sin sa dóis go bhuiid ábalta níomháin cosca chur a scapú an vírus a cosca chur as an vírus a seaamach.
Ó héh na tuthe altranis agus an scéiretá anarmáidin gur dúrú leis na tuthe altranis gan rá leis na teilig gur a cósna ins na tuthe altranis bhfuil éon rud rá agat faoin scéil sin.
Bhain si táhaach go rís réir mar sceaptar an vírus de si níos táhataí an non go sceaptar an méid ólas mar grád a an duine a fiúháin na húdarás na tuthe altranis agus na doctorí agus na bhaintítá ag obair. So ní híam le scarabé go méid cosc ar ólas atá cí agus cór a scapo a mu sa phobal sa tí aldris na húdaras mar dúirt sé ceanna, so ní an tím leis an raigh sin a scarabé.
Sásta Orla? Okay, or Margaret. Priscilla, did I see your pen up there?
In relation to the private hospitals, how many consultants have signed up out of the 600? And I know some of them have resigned. And just given the indications that we're going to continue using the private hospitals as you need the capacity, is there any indications that they might change the approach and possibly use the NTPF as a funding mechanism instead of the controversial contracts that don't seem to be appealing to private consultants at the moment?
The number signed up as of Friday was 289, just short of 290. Still hopeful some others may sign up over the coming days. I don't have a number of those who will have withdrawn just this morning, but we certainly can get that for you. Just on any specific changes to the contract going forward, I don't expect so. Ultimately, the whole review and what way it progresses now in terms of the current contractual agreements with the private hospitals is ultimately the decision for government. But certainly I've relayed our position, our perspective on it is that we do need capacity, we do need to retain capacity for the coming weeks and months ahead of us. But ultimately it'll be a decision for government, but I don't expect currently changes to contracts.
People turn up at emergency departments is access to diagnostics, because otherwise they could be waiting over a year or two for an MRI or a CAT scan, so they often turn up at an ED with the GP letter. Obviously you'll be trying to reduce that in the winter, so I think, did you mention that there will be increased capacity for diagnostics in the community for GPs perhaps?
Well, we have, I suppose in terms of how we access diagnostics, actually we use the private hospitals quite a lot for diagnostics, and we would see a lot of activity there. But for us, certainly, there are some diagnostics that are more readily accessible for GPs, like ultrasound or whatever. When it comes to X-rays, MRIs, it's a bit more complicated, and we know that we have had significant waiting lists for MRIs. So for us, looking at that in the round, we need to determine what we need to be able to support GPs to do more of, and what's, whether it's other multidisciplinary professionals around them or better access to diagnostics. That's something we'll be working through, but that would have been a focus for us anyway in our response to winter. And it's important to note, just when Paul's mentioning the private hospitals there, for us in a normal year, winter planning would be starting fairly soon. So I think we have to constantly be on this moving forward in terms of just looking at how we can better prepare our system for any surge related to COVID, winter, flu, whatever it might be. But diagnostics is key for us, absolutely.
Okay, okay, Simon, back to you then.
Just two final questions from me. Just in relation to contact tracing in complex cases, Paul, the 2.3 days median that you're down to is quite strong. How is it for those complex cases where contact tracing involves, let's say, healthcare workers? And just a general question, Colm, why is it that our healthcare workers have much higher infection rates than other countries? We're running at about 31-32%. And in Italy and Spain, it's in around mid-teens. In the UK, it's in around that. Why is that?
So we'll start with you, Paul.
Yeah, just on the complex cases, we put stronger procedures in place in terms of with our public health teams for them to follow through in terms of some of the more complex ones. As I mentioned on the change management plan, when we launched our testing and tracing strategy on the 14th of May, we were aiming that 90% of them would be completed within 3 days. And then we have some of the more complex ones over the following days. Thankfully, we're performing quite strong, as you've mentioned. The median is 2.3 days overall, and it's a smaller number now. Would go beyond that.
Okay, Colin.
Clearly, concern to us, 31-32% of the total number of cases confirmed are healthcare workers. In trying to explain that, and you're right that in other countries where there's been widespread transmission, it's not been so high. But when we're comparing between countries, we're not always comparing the same thing. So we know in our country we had difficulties with testing in terms of the volume of testing at one stage. But throughout all our difficulties, even when our volume of testing went very low, we continued to prioritise healthcare workers. So even when we weren't testing other areas that we wanted to test, we continued to test that cohort of people. So they may represent a disproportionate amount of our earlier testing and medium testing phase. Now that we're testing on a much broader scale and a much higher volume of people, we see the proportion of healthcare workers of the total number of positive cases reduced. As to why it's happened in those people who've had it, we know that in some cases, in the early stage of the pandemic, it was somewhat travel related when the case definition related to travel. In the medium phase, if you like, it was predominantly related to community transmission, meaning that there was more widespread dissemination of the virus within the community for healthcare workers and non-healthcare workers. And in the latter stage, as it became what's called nosocomial, meaning that for people, healthcare workers who got COVID-19 predominantly got in a healthcare environment. And as we tightened up our infection prevention control, particularly in the community setting, our hospital setting would have been well versed in Clostridium difficile, MRSA, and other bugs that they would have to control. They would have long experience in dealing with outbreaks. That measure has begun to kick in with reduced amounts of healthcare workers turning positive, but it is a serious statistic, one that's a cause of concern for us. But as I say, when comparing to other countries, we don't have the same story as other countries in terms of testing or in terms of the reason behind the positivity rate.
That's you, Simon. Clean up. Anything else? Good. Anybody else? Okay. Thank you. Think that's also okay. So thank you very much for coming here today. Hope you found it useful and informative. I'd like to thank the panel for their presentations and answering questions, hopefully so well. And until the next time, which we plan to do at some stage during the week, probably on Thursday will be our next weekly briefing. Okay, so listen, thank you very much, and thank you for everybody who tuned in at home, and we'll see you at the next briefing. Thank you.